This is Where We Live on Connecticut Public Radio. I'm Lucy Nalpathanchel. Most of us have a personal connection to cancer. It kills 1,600 people a day in our country. A personal connection, the loss of his son, led then Vice President Joe Biden to lead a cancer moonshot in 2016, aimed at reducing the lives lost. And just last week now, President Biden relaunched the effort to reduce the number of deaths from cancer by at least half over the next 25 years and to improve the lives of survivors and their families. Today, Where We Live, what lessons can we learn from the fight against cancer? It's the focus of the book, A New Deal for Cancer, Lessons from a 50-Year War. It's a compilation of essays from leading professionals who touch quote, Cancerland in some way. How can the country, including the government, healthcare providers, and the private sector, work to do a better job in prevention and achieving better outcomes for all cancer patients? We want to hear from you, too. You can join us, 888-720-9677. That's 888-720-WMPR. You can share a comment on our Facebook page and find us on Twitter at Where We Live. The book's editors join us now on Zoom. Abbe Gluck is professor of law and faculty director at the Solomon Center for Health, Law, and Policy at Yale Law School. She's also a professor of medicine at Yale. Abbe, welcome to our show.
Thanks so much for having us.
Also with us on Zoom, Dr. Charles Fuchs, Senior Vice President of the Global and Global Head of Hematology and Oncology Product Development at Genentech and Roche. He's also an adjunct professor at Yale. Charles, welcome to our show.
Good morning. Thank you for inviting us.
So, Abbe, I'll start with you. When we think about the lessons learned in this 50-year war, now 51, since Nixon's National Cancer Act of 1971, talk through what prompted this book.
Well, thanks for that question. So, as you started with, Charlie and I both have personal connections to cancer, close family members who suffered from cancer, and we're also in the cancer space. Charlie is a leading physician, obviously, and I'm a lawyer and I do health policy and have for a long time wanted to be involved in the cancer space to think about law, policy, institutions beyond the science, what we can do with all aspects of our national culture to address the disease. I approached Charlie about this about 6 years ago now to talk about how we could collaborate. And we looked around and we really saw that there had not been a thinking through of this issue in the way that we would like to do it. We had the largest cancer conference in Connecticut history to start to explore these issues. More than 700 people came from across the nation. And the book grew out of that. And it's our effort, as we say, to explore everything beyond the science. The science has been spectacular. The science has given us the luxury of thinking bigger and thinking broader. And this book is our effort to take a 360-degree lens to how cancer touches every aspect of our legal and policy and healthcare system and think about how to approach it from that broad angle.
I mentioned the National Cancer Act of 1971. Back then, the claim to find a cure for cancer 5 years after the launch. One critic has said the idea of curing cancer was like landing a man on the moon without understanding the laws of gravity. So when we think about the moonshot and what now President Biden has relaunched, walk us through some of the challenges. Charles, I'll go to you.
Absolutely, and I think you're absolutely right. The goals of the War on Cancer Act, as it was in 1971, certainly were audacious, perhaps unrealistic, right? That we would eliminate cancer by the bicentennial or 5 years later. But there's a big difference then and now. One is we've made a lot of progress over the past 50 years in terms of our ability to prevent, treat, and understand cancer. But where we stand now is really unprecedented compared to where we imagine it. The issue then, which is not the issue now, is we now have a much greater understanding of the biology of cancer, of the susceptibilities, that cancer is not one disease, but hundreds, perhaps thousands, defined by various characteristics, including genetic drivers. And we have the tools to particularly target those unique genetic susceptibilities of cancer. And I think the pace of progress is much greater. The goal that President Biden set forth to cut the death rate by 50% over the next 25 years, I think is realistic. You may have heard even some people think that the goal should be even more audacious. But if we can overachieve that, all the better. but we're in a much better place now to make that kind of progress.
Abbe, did you want to also respond to that question? Because when we think about the people that are unfortunately dying today from cancer, the disparities that still exist. So when we look at the next 50 years, thinking about how to make sure that treatment and care, including prevention, reaches all populations, because that's not happening equally.
Thanks for that. You read our book. And so you're hitting all the notes that we want to hit. And so, what's really interesting about the renewed moonshot that President Biden announced last week is that it's already different from the Obama-Biden cancer moonshot that happened in 2016. That was an effort to really bring together the private and public sector, break down fragmentation, and galvanize coordination, cooperation, and speed. What President Biden has done now is different. And I think it's informed by the work he's done in the COVID space. He's taking a much broader approach to the problem, very similar to the one that we take in this book. So as you hit on, there are a lot of things that the National Cancer Act did not address in 1971, whether these issues were not on the radar screen or whether the science just wasn't advanced enough to give us the luxury to consider them. But healthcare disparities is a huge issue, one that COVID has shined a bright light on, but which has always been there. We have intolerable healthcare disparities in cancer that are largely caused by inequitable access to screening, prevention, and treatment. There have been some really interesting experiments in cities like New York and states like Delaware, where a targeted emphasis on prevention and screening in underprivileged populations has eliminated disparities. So this particular moonshot effort is focused on that, as well as many other things. You mentioned prevention. 1/3 of cancers are preventable. We spend a very little percentage of our health policy budget on public health and prevention. Tobacco and obesity are huge predictors of cancer, and predictors of cancer that fall disproportionately on populations of different socioeconomic status. The next 50 years has to be more focused on prevention. We can talk more about that, Lucy, if you want. Just to give you one other example in the same vein, you have to think about health insurance, right? In 1971, Medicare and Medicaid were just 6 years old. Today, we have the Affordable Care Act. The Affordable Care Act has made great strides in providing insurance to millions more Americans, and lack of insurance is a very significant predictor of poor cancer outcomes. But yet, we have more work to do. We've got 12 states that haven't expanded Medicaid to their low-income populations. That's millions more people who don't have access to insurance and so won't have access to quality cancer care when they need it.
You're hearing Abbe Gluck here on Where We Live, professor of law and faculty director at the Solomon Center for Health Law and Policy at Yale Law School. She's also a professor of medicine at Yale and editor of this book, A New Deal for Cancer, Lessons from a 50-Year War. Co-editor Dr. Charles Fuchs is with us, senior vice president of global head of Hematology and Oncology product development at Genentech and Roche. So let's talk more about the funding, Charles. When we look at this relaunch of the cancer moonshot, and as Abbe mentioned, a lot of the money is not being spent on prevention. Why is that?
That's a great question, and it's something that I've committed my career to. Is when Abbe approached me, it was during my tenure as director of the Yale Cancer Center, and I think as Abbe said, we wanted to take a holistic view. Really, over the history of the past 50 years, we've really underspent on prevention. In fact, we spend about 3% of federal investments into prevention. And yet, in fact, in cancer, probably the greatest impact we've made has been in prevention, in diminishing tobacco use, among other things. We clearly have a long ways to go. Even within Connecticut specifically, we need to reduce tobacco use. We need to address the issues of obesity, about exposure to environmental carcinogens, as well as vaccination for HPV. And so we need to advance prevention research. And I think that is a focus of the White House initiative. And we need to ensure that we advance prevention equitably. One other really important issue beyond primary prevention is early detection or screening. We clearly underutilize that. That's a particular issue with regard to disparities in underrepresented populations. As well, COVID has had an impact during my tenure at Smilow Cancer Hospital and Yale Cancer Center, and this was a national phenomenon, in the first several months of the pandemic, cancer screening declined by 80%. We have a lot to catch up on. And in fact, some of the gains we've made in reductions in cancer mortality may be diminished as a result of this pandemic, and something we have to catch up upon.
That stat you share is really troubling, and I think Abbe, Congresswoman DeLauro, hit on that in her essay that I believe you were also involved in. So can you talk more about what Charles shared?
Yeah, so in our joint chapter, we talked about sort of both of these points that Charlie made. One is the fact that, yeah, people did not get their routine cancer screenings during the pandemic, both because people were locked down and because in many places access to non-essential health services was delayed. And at the time, in many states, screening was considered a, quote, non-essential service. But of course, it's very essential. And one of the things that President Biden actually mentioned last week when he renewed the moonshot was a focus on this catching up. The danger is that even if we do catch up, detection is made later in the progress of the disease. And obviously, the later one is diagnosed when it comes to cancer, the more likely it would be that the cancer has spread and you could be diagnosed at a later stage. I think they call this upstaging, but Charlie can correct me if I'm wrong. And we obviously do better when detection is early. I did want to add on to one other interesting point from a lawyer's perspective, and that does touch on my chapter with Congresswoman DeLauro that Charlie mentioned about the amount that we invest in prevention. This is a great statistic and one I'm obsessed with. The CDC's entire budget, right? The entire budget for the 2021 fiscal year is basically the same amount as the amount we spent on cancer, right? Cancer alone. This is the entire budget the CDC has, basically, which is a number that is enormous. It includes the pandemic, that includes everything that we have going on. We don't invest in prevention. For Congress, it's also a problem with the way we score bills. Legislation has to have a budget score. It has to be neutral when it comes to the budget deficit. Prevention is investment today for gains tomorrow. And as we point out in our chapter, that's unattractive sometimes from a budgetary perspective because it's hard to score prevention effectively, even if down the line it's going to save us a ton of money. At the moment it passes in Congress, it costs money to invest in prevention. That's a disincentive. That's a pathology of our legislative process that we really need to correct if we want to be sure to invest in prevention going forward.
We're talking about a new deal for cancer, lessons from a 50-year war. I wanted to take a quick call from a listener. Bud's calling in from New London. Bud, what did you want to share?
Hi, this is Bud McAllister, Partners in Healthy Communities, New London. I started my organization in 2010 when Father Emmett from St. Francis House and 11 other people I'm either close to or principal in one of the organizations that I work with were all diagnosed with cancer within 30 days of each other. And I think that that's probably mathematically impossible, but it happened.
So, Charles, when you hear Bud talking about, starting partners in health communities after 12 members of the community were diagnosed so closely together, I understand that's still active and still working to mobilize the community. What does that mean when you hear that and the idea that patients are self-mobilizing, how it impacts both the treatment process for them and survivorship?
Well, I think you raise a number of issues, as does the caller, which is on the order of about 40% of Americans are ultimately going to develop cancer in their lifetime. So, this is a very common ailment, and it touches the lives of our neighbors, our friends, our family members. And as Abbe and I defined in our opening of the book, we both have had family members affected. So, hearing that so many people in the community are affected, that certainly is not altogether uncommon. It's disturbing. It certainly raises a concern about, is there something in the community? And that's something obviously should always be investigated if there are a cluster. But at the same time, there's just so many issues that you ask about, Lucy, and I'll focus on one in particular beyond treatment, which is survivorship. When President Nixon signed the War on Cancer Act, at the time, we were approaching curing 1 in 3 Americans with cancer. We're now curing more than 60%. Still inadequate, but we're better. And as we continue to get better, we're now finding more people who are survivors of cancer, who still have issues, health issues in particular, social issues, financial issues. And we have to address that. In 2030, we'll have almost 25 million cancer survivors in the United States. And we have to make sure we care for those individuals, that we have the infrastructure to do it, to provide their long-term needs, because cancer is not simply the treatment process, which is important. It's also the process after treatment, how we help people acclimate following that, emotionally, physically, psychologically, financially. And we need to have the resources to be able to deliver that.
That's Charles Fuchs, Senior Vice President and Global Head of Hematology and Oncology Product Development at Genentech and Roche. He edited the book, A New Deal for Cancer, Lessons from a 50-Year War, as well as Abbe Gluck, who's with us, Professor of Law and Faculty Director of the Solomon Center for Health, Law, and Policy at Yale Law School. We'll continue talking after the break. What questions do you have about the next 50-year fight against cancer? You can join us, too. Eileen tweeted, on behalf of my friend who died from breast cancer recurrence in 2016, I know the provision in the Affordable Care Act to cover pre-existing conditions was essential to her survival. You can join us, 888-720-9677, or find us on Facebook and Twitter at Where We Live. This is Where We Live on Connecticut Public Radio. I'm Lucy Nalpathanchel. The science of cancer has advanced significantly since the National Cancer Act was first signed in 1971. But how will the country work towards fewer deaths and equitable treatment and care for all Americans over the next 50 years? It's the focus of a compilation of essays in the book, A New Deal for Cancer. With us are the editors, Abbe Gluck, Professor of Law and Faculty Director of the Solomon Center for Health, Law, and Policy at Yale Law School, and Dr. Charles Fuchs, Senior Vice President and Global Head of Hematology and Oncology Product Development at Genentech and Roche. He's also an adjunct professor at Yale. Abbe, when we talk about the contributors in this book, the book starts with Pulitzer Prize-winning physician Siddhartha Mukherjee, who writes about how we as a society live in, quote, cancer land. So let's talk more about that, this state of hypervigilance with advancements in science and the consequences.
Yeah, so Sid's chapter is a really powerful way to begin the book. It frames sort of where we are now, that the advances in the science have ironically brought on new kinds of anxieties. For many of us who have relatives who've had cancer, we live in a state of fear that it'll happen to us, or a state of surveillance, as Sid puts it, in the sense of getting routine diagnostics yearly, year in, year out, especially if you're at risk for particular cancers. So there's a trade-off between the science that we have advanced and the important benefits of early detection with this sort of constant state of being under surveillance or feeling like we're all going to be targets of cancer in our lifetime. And how we manage that, how we manage our scientific advances with the anxiety that comes along with those screenings is really important. That chapter focuses on a couple of things for us to think about for the next 50 years. Among them are the dangers of overtreatment. Too much screening might lead to overtreatment for diseases that otherwise wouldn't have been treated. Then, I myself worried about equity. I think we're going to see new disparities issues. The more preventative screening there is, the more early detection there is, it's going to open an access gap between people who have and people who don't have, unless we simultaneously are laser focused on making sure that those advances are available to everyone.
Charles, I wanted to get your take on the Cancerland chapter as well, and this state of hypervigilance that we are now a part of in our society.
No, I think Sid's observations are really important. As I mentioned earlier, no one is immune from this. We are all at risk. And just as one narrative, one anecdote, my career has principally been focused on both the research, treatment, and care for patients with colorectal cancer, a very common disease. And it's something that I really focused on, both clinically as well as research. And a number of years ago, at a relatively young age, my wife, Joanna, was diagnosed with colon cancer, which is, ironic given it's my life's work. Now, fortunately, she's done well and she's a proud cancer survivor. But you really do see the other side of it as opposed to a practitioner when you have a loved one with it. And as part of that process, what we also learned over time was that my wife and her family have not one, but two cancer susceptibility genes. And this is increasingly the case. I think what Sid really alludes to, as we continue to understand the genetic risk factors, as we expand genetic testing, we're going to all learn that we have certain lifetime susceptibilities. And so how do we deal with that, both in terms of delivery of prevention and medical care, as well as the psychological burden of these things?
Deborah from Watertown wanted to share this comment with you both. Her ex-husband died a few months ago at 62 from colon cancer. And she writes, absolutely one of those cases where regular screening didn't happen due to COVID and had some symptoms, one of the many preventable deaths due to COVID. Charles, did you want to respond to what we shared? Because I think earlier we also hit on the point that there is right now no incentive to diagnose, but the incentive is to treat.
Yeah, well, I want to offer my condolences to Deborah and her family. And, we hear these stories all too often. Colon cancer is preventable. We know that colonoscopies work. They don't detect every cancer, but they can reduce cancer mortality, colon cancer mortality, by up to 75 to 80% beyond other things. And in fact, the other aspects of prevention really apply here. We don't do as good a job in ensuring that we deliver effective prevention for colon cancer, as well as the other major cancers, lung cancers and others. We need to do a better job. We need to make sure it's accessed. We need to help patients get it. There are efforts to make colonoscopies covered by insurance, but we still don't do a good enough job making sure that everyone gets it.
You can join us 888-720-9677 or find us on Facebook and Twitter at Where We Live. Abbe, the book also looks into the economics of cancer, so the growing lack of access to small physician-owned oncology practices as more venture capital, hospital-owned practices are created. Let's talk about the impact on the quality of patient care and also the cost of care.
Yeah, those are great questions, and the book tackles those in several different ways. So, one interesting statistic is that about 63% of American patients are treated in the community cancer setting every year. So basically, a lot of people have access to local cancer practices, but many people have to drive more than an hour to get to a major cancer center. And, we're just talking about prevention. I also want to really extend my condolences to Deborah and her family. Having access to an oncology practice is essential for getting quality care if you have cancer, but also getting screening and detection and treatment on the early side. So we have a landscape of a cancer business where we are losing many of our small practices to the economic pressures of consolidation. And the danger is that people are not going to have a local oncology practice near them. Our authors argue that everybody should have a community practice or a local practice nearby, but also have access to the expertise that major cancer centers like we here at Yale have to offer. And, with the advent of telemedicine and more sharing of electronic health records, there are ample opportunities for community practices to work closely with those national cancer centers when patients need more than the community centers can offer. At the same time, we have a fascinating chapter by Dr. Ed Benz, who is the head of the Dana-Farber Cancer Institute over at Harvard, where he talks about the economics of the cancer business for those big cancer centers. And he talks about this phenomenon of cross-subsidization, which he describes in the following way. We are over-incentivized to charge lots of money for the big services like scans, surgery, chemotherapy. But a lot of the value that these cancer centers offer are things that don't pay very much, whether it's palliative care, whether it's research, whether it's second opinions. So the way we pay for cancer care doesn't make much sense. If we decide to say slash drug prices like everybody in Washington wants to, we have to think about the ripple effect that might have on the services right now that those high drug prices subsidize, whether it's a second opinion, whether it's research, whether it's palliative care, whether it's other social services that these cancer centers offer to patients who need them. So we have to think about the system holistically. The one more thing I'll add about pricing is that pricing was not a major topic of discussion in 1971. We didn't have the various different health programs we have in place, and we didn't have this national pricing conversation that we're in today. But today we do have a national healthcare pricing conversation underway, and we are thinking about ways to move away from fee-for-service, where doctors get paid for every procedure, an economic incentive that increases the desire to perhaps prescribe those procedures, to payment that covers the whole course of treatment, the whole course of care in a coordinated way, and that thinks about outcomes. And as we move toward those more modern theories of payment, it's going to be interesting to see how cancer comes along for the ride.
I'm curious your take, Charles, as the former director of Yale Cancer Center, as we hear Abbe describe the current reimbursement system and how it's deeply flawed.
Yeah, I think it's an important point that our colleague Ed Benz makes, which is in our ability at Smilow Cancer Hospital and Yale Cancer Center and our centers across the state, our ability to deliver the comprehensive care that patients need. And I don't mean simply the doctors and nurses. I mean nutrition, social work, physical therapy, among others. To do that, we really have to be creative with our accounting. Namely, yes, certain aspects like procedures, CAT scans, drugs get paid for, but we don't get adequately reimbursed for all those other important services, including emotional and physical services, nutrition. And to do that, we need to make sure that we're properly reimbursed for those others so we have the ability to use those dollars to cover it. I would also add our ability to deliver clinical trials and research are subsidized by those dollars. Now, I think what Ed Benz points out is let's have a more rational approach to funding cancer care so that we do adequately cover those important things like social work, nutrition, the ability to access clinical trials so that we can truly deliver the promise of comprehensive cancer care. I'm really proud of what I did and we all did during my tenure at Yale and Smilow. I think we've really tried to make sure that every patient gets access to comprehensive care. As well, we've really wanted to make sure that we create centers within the communities so patients have access to that kind of comprehensive care. But it's a stretch sometimes to ensure that we have the dollars given the current methods of reimbursement.
You mentioned Ed Benz. Again, that's the former CEO of Dana-Farber. So when we think about the high cost of these drugs for treatment, can we also talk about, the process for research and development and how I believe in this book there was, focus on how at times this can also be costly and ineffective. There's also redundancy there, Abbe.
Yeah, I'll start with that answer, and then Charlie's obviously working in this space, so I'll let you hand it to him. From the lawyer's perspective, what the book offers on these points are several. One is this idea that in the federal government, there is a lot of redundancy. There are a whole bunch of agencies that overlap in the cancer space. Rich Shilsky, a doctor who wrote our chapter on agency fragmentation, makes a couple of great points about this, and one of which he says is, why not combine the process of FDA approval of a drug and Center for Medicare and Medicaid Services decision on how they're going to cover the drug, so that when a drug is approved, wouldn't it be nice if you knew if it was going to be covered by insurance? That's one way in which you can have that kind of collaboration. The Biden Cancer Moonshot from 2016 incentivized a couple of really high-profile collaborations across departments, like the Department of Defense with the Department of Health. Those can be very effective. In other aspects of the book, in the context of R&D, we've had our authors talking about using the power and the purse of the federal government to de-risk early stage R&D, which is really expensive and really hard to get off the ground, make it less risky for companies to try a lot of things in the early stages, so they can put their efforts into later stage development. I'll let Charlie talk about that. And there's one other thing that the current moonshot is highlighting, and that our book also highlights, is that, there are a lot of cancers that are rare and that don't affect a lot of people. And as we move into an era of precision medicine where cancers are many and more specified according to genetic makeup, there are going to be more and more cancers that affect fewer and fewer people as we define them. And we're going to have to find a way to incentivize companies economically to develop drugs, even if those drugs are only going to target a small number of people. Congress has a role to play there in providing financial incentives and other incentives to make sure that those kind of drugs are developed so that all kinds of cancers are treated.
Before I go to Charles, in the book, I believe what you're just talking about related to childhood cancer and the development of drugs and treatments there, Abbe.
Yeah, that's one example. We have a wonderful chapter from a pediatric cancer advocate, Nancy Goodman, who lost her son to cancer. And as an attorney, she's devoted her life to creating legislative incentives through Congress to get companies to make pediatric drugs. So one of her past legislative acts was a statute that actually gives drug companies a voucher that lets them kind of cut ahead of the line the next time they make a different drug, if they develop a drug for the pediatric population that might not be as lucrative.
So Charles, I wanted to get your take on the R&D process and, how to make it, more effective, because we know it can be pretty costly on the front end.
It's very costly, and it frankly needs to happen quicker. That is, our ability from taking an initial discovery in the lab to a patient, to delivering a drug to a patient and getting approval, is something we need to accelerate. And I know that all agencies are working on that in conjunction with industry and the academic community. But it's something that, as Abbe said, we are too fragmented. And I'll just give you one example where fragmentation is an issue. We generate reams of data in the care of patients with cancer, as well as the conduct of research. But they're all siloed between hospitals, academic institutions, industry, research centers, among others. You think about the power of what internet and social media companies do and everything they know about us. We're sitting on a gold mine of data across the United States. That is, we would be able, with artificial intelligence and other means, we could find those needles in a haystack just looking at the treatment and natural history of cancers of patients across the United States. That's our laboratory. And I think in Charles Sawyer's and colleagues, in one of our chapters, actually discusses the need to enable legislation such that we can pool those data and ensure that researchers have access to find those insights.
We got a comment from a listener on Twitter who wrote, please help bring, I believe it's URSO, to clinical trials. I believe that's related to breast cancer. So the public really pushing for new advances, Abbe. So let's talk about that from what the public wants to see, and how to get that included in this efforts for progress in the fight against cancer.
Yeah, we have, the public, cancer advocates have had a historic role to play in cancer process. The 71 Cancer Act is by and large credited in large part to the efforts of a woman named Mary Lasker, a very famous cancer advocate. And in the book, we tell the stories of many members of the public who've had instrumental roles in raising awareness for certain cancers and pushing Congress and the private sector to make strides. Sherry Lansing, the famous entertainment executive, lost her own mother to cancer. She's one of the co-founders of Stand Up to Cancer. They've given hundreds of millions of dollars to fast-paced collaborative cancer research. I told you the story of Nancy Goodman. And there's another story in the book about a different group that has used social media to raise awareness for certain kinds of cancers and certain kinds of trials. So the message is that you, the public, have a very important role to play, have always historically had a role to play in elevating these issues. There's one counterpoint to this that I'd just like to acknowledge, which is another debate we discuss in the book, which is that there's always this question about whether we want to focus Congress's efforts on cancer as a whole or on specific cancers. You don't want there to be a fight among cancers, different cancers fighting for different kinds of money, especially because there's valuable research that benefits many different kinds of cancers across the board. There's a balance between raising awareness for a particular kind of cancer and trying to fund the cancer space as a whole. Obviously, people suffering from particular cancers are going to want to raise awareness for their cancers, and that's understandable and important to do. It's just important to think about the balance.
Charles, I'm going to end with you. Before we head to break, we talked about the new cancer moonshot. There's a lot in this book that you and Abbe edited for people to consider when we think about progress needed with the science of cures, but progress with the people and institutions that also make up the system. And so what do you want to see in the next couple of years in this progress? What are some next steps?
Well, I think it's in part collaboration across academic institutions, hospitals, industry, and I think we're seeing more of that. But as well, I think we need to make sure that we focus on the right questions. There are two great examples. One was the Human Genome Project, where, we had a very focused project. We were determined to sequence the entire human genome, which we did over a long period of time, but done, and now that technology is routinely available. But so many insights were gained from that understanding. And so those kinds of projects, which I think are essentially part of the Biden and White House initiative, those are the things we want to focus on. Figure out what are the high risk, high reward projects that will be transformative, and to ensure that we are all working together to achieve that goal.
That's Dr. Charles Fuchs, again, Senior Vice President and Global Head of Hematology and Oncology Product Development at Genentech and Roche, editor of A New Deal for Cancer, Lessons from a 50-Year War. Thank you for your time today, Charles.
Thank you.
And the other editor, Abbe Gluck, Professor of Law and Faculty Director at the Solomon Center for Health Law and Policy at Yale Law School. She's also Professor of Medicine at Yale. Abbe, thank you so much for your perspective today.
Thanks for having us, and thanks to all the callers who called in and commented.
This is Where We Live on Connecticut Public Radio. Coming up, we're going to talk to Project Access New Haven about how it works to improve screenings and treatment in communities that see many health disparities. You can join us too, 888-720-9677, or find us on Facebook and Twitter at Where We Live. This is Where We Live on Connecticut Public Radio. I'm Lucy Nalpathanchel. We know that government plays an important role in helping save more Americans from cancer, one of the leading causes of death in our country. In the new book, A New Deal for Cancer, Lessons from a 50-Year War, Connecticut Congresswoman Rosa DeLauro, also a cancer survivor, writes that Congress should be guided by knowledge that many Americans will be diagnosed with cancer at later stages because of missed or delayed screening caused by the pandemic. With that in mind, we wanted to talk about a local model that focuses on prevention, on screenings, and also treatment in communities that see a lot of health disparities. With us on Zoom is Giselle Carlotta MacDonald, Executive Director of Project Access New Haven. Giselle, welcome to the show.
Hi, good morning. Thank you so much for having me.
I wanted to learn more about the work that you and your team are doing in the greater New Haven area. I understand Project Access arranges for donated care from specialists for patients in that region. So let's talk about the community and how you help them get treatment and screenings for cancer.
Thank you for that question. So just to give you a little background of Project Access, we were founded by providers from local providers here in New Haven that saw a gap in the area with the uninsured population with access to specialty care. So they jumped into action and they started a nonprofit that is known as Project Access New Haven. And they followed a model that was developed in 1996 in Asheville, North Carolina. And as you mentioned, it follows the volunteer provider network model. And I also wanted to mention that at the core of the service at Project Access, we have patient navigators and community health workers that support the outreach and support the navigation to patients with access to specialty care and also access to screenings.
So when we think about the community you're serving specifically, many or all are uninsured, Giselle. And we heard earlier from our other guests, when we think about outcomes, access to insurance, that's how you're going to, survive and beat cancer most likely. And so let's talk about some of the challenges you're seeing in the community.
Yes, it's, as we all know, the number one cause of bankruptcy in the United States is the medical expenses, right? So insurance, even though after the Affordable Care Act, what we've seen is that there are still individuals that are uninsurable. And there's also still individuals that don't know that they may qualify for insurance. So we start first with addressing the barriers to care, access to care for those uninsured patients. Most of the referrals come to us from the federal qualified clinics in the area, and in partnership with the hospitals, Yale Medicine, the providers in Northeast Medical Group, and also private practices. What we do is we coordinate donated care for these patients that are being referred to us as having an urgent need. As well as our patient navigators are able to identify when a patient may qualify for insurance. So we're able to also help them with their enrollment through Access Health CT. And, just to share a little bit more about what we see when we talk about barriers. And it was a great conversation to hear about, with all the research done, what we continue to see is not only financial barriers, insurance, through insurance, but also, the emotional support that patients may have, especially when it comes to cancer screenings and when they're diagnosed. So a lot of what our team, what the navigators, the CHWs, the community health workers do is work with each patient to address the barriers that we see. And it could look from access to healthy food, access to transportation before and after an appointment, also reminder calls, right? Because the patients that we serve might have stress that they're dealing with, not only through the cancer diagnosis, but also life stressors. So being there for the patient, providing emotional support, and also language barriers. We have a large number of patients that we serve that are only monolingual in Spanish or other languages, so making sure that they understand the information that they're being given by the providers, by the clinicians. So we act as that linkage in between the clinical team, the social workers, pharmacists, and just being there for the patients and also being there for the clinicians.
You bring up some important points because when we think about regular screenings, so one of the things that people need to do or need help with is scheduling a screening, but it may not even be that simple for some because it depends on, the type of job they have. Can they get away from work for a couple of hours? And as you mentioned, transportation and childcare, it's complicated depending on a person's situation, Giselle.
Yes, absolutely. And I call it the peeling the onion, right? So working with the patient to understand all the different needs, because it's usually not one, but many. There's a complexity of social needs, emotional needs. A lot of our patients are unable to take time off from work because that's their only source of income. So working with them and the providers to see if there's any clinics in the evening hours, weekend hours to help the patient get to those appointments. And also, as you mentioned, just making that phone call can be very, very challenging. I remember a time that I helped someone out in the community that she let me know that she tried to schedule a mammogram, and she was having some challenges because the person on the other line only spoke English. So I made that call with the patient, and I was able to schedule. But there's so many patients, just like this case, that, it could be language barriers. It could be that they don't have the time off from work, or they're not insured, or they're afraid of the copay or the cost for that appointment, or they're just afraid because they're misinformed. So also providing accurate information about the screening process. Our patient navigators are able to provide information about how to prep and what to expect before a screening, and also what to expect if there is a diagnosis and what is the next step. And that can help with the fear and the anxiety before an appointment.
So what have been the outcomes that Project Access has seen in the greater New Haven area when we think about, is this model available in other places in our state, Giselle?
Great question. So one outcome that we like to highlight is our no-show rate. So we know that most vulnerable populations, patients uninsured and underserved, usually are known to have a higher no-show rate. And with this model, we have throughout the 12 years that we have been in existence, we have had a 3% or lower rate of no-show. And that's thanks to the coordination and the efforts from the patient navigators in working with the patient and also working with our providers in scheduling those appointments when it's best for both the clinician and also for the patient, and also supporting with transportation, making sure that they can get there. So it's not just scheduling the appointment, but also helping them get there through information of how to, bus transportation, or also providing free taxi rides. So we have a partnership with M7, and they're able to support our patients if there is a need for transportation.
Mm. We mentioned at the top that this is donated care from specialists for patients in the greater New Haven area. So can we talk about just briefly the kind of care they're receiving through this donated care, Giselle? Because we hear so often about the backlogs caused by the pandemic and people having trouble even getting appointments.
Yeah, there's so many barriers, and there's definitely an impact post-COVID. So we did see during COVID the challenges with getting patients into being seen on time. So in 2020, 2021, we spent a lot of time advocating for the patients that we saw that needed a timely access to appointment. And it's all thanks to the collaboration and coordination that happens with our team. We have an RN patient navigator manager that also advocates when there is a patient that needs needs access to appointments sooner than later. We do, recognize that this is all thanks to the partnerships that we have with the hospitals, with the clinics, in making sure that we advocate for these patients to get access in a timely manner.
And just to put a finer point on this, without the work that you and your team have been doing, when people need care, their other option would be the ER, Giselle?
That's correct. Our founders created and started this program because of the gap that they were seeing in the greater New Haven area with access to specialty care. And the gap that we're trying to address is the avoiding the ED, the emergency department visits. So these are patients are likely to either delay the care, have a longer wait for appointments, and eventually they would end up in the emergency departments.
Well, Giselle, Carlotta, MacDonald, thank you so much for coming on to talk about the work that you are doing, you and your team. Giselle's Executive Director of Project Access New Haven. We appreciate your time today.
Thank you so much for having me.
I'm Lucy Nalpathanchel. Today's show produced by Sujata Srinivasan. Our technical director is Kat Pastor. You can listen to Where We Live anytime. Just download the show on your favorite podcast app. We'll be back tomorrow.